Hi, I'm Meredith Mueller, and I'm faculty in the Department of Physical Medicine and Rehab, as well as the Research Integrity Officer for the department. My presentation today is going to go over how we determine whether a project meets the definition of human subjects research, or whether it can be considered quality improvement, program evaluation, or not human subjects research. I did give this talk during one of our faculty meetings, but for those of you who weren't able to attend, or for those who were and just want a refresher, we decided to put this presentation on our research website for review. So at the University of Colorado, Denver, we do allow PIs to self-certify that their project does not meet the definition of human subjects research. It's a little different if you are doing a project at Children's Hospital or at the VA Medical Center. So at Children's Hospital, they do have a committee called ORCORC that wants to look at all of the projects prospectively and determine whether the institution wants to support the project or not, and therefore whether that project can commence at the institution. And then at the VA Medical Center, they require all QI, program evaluation, or other research studies that don't meet the definition of human subjects research to be reviewed prospectively by their R&D committee. So if you're 100% certain that your project doesn't meet the human subjects regulations, then you can self-certify that it is a QI or program evaluation project. However, if you're not 100% certain of this determination, then you should seek guidance from someone within your department, or even at the local IRB to help make that determination. Because what's happened is that investigators on campus, as well as within our department, have self-certified something as, for example, QI. They've completed the project, they've disseminated the information either through publication or presentation at a conference, and then found out after the fact that, hey, wait a second, this indeed was research. They could find out if there was some type of audit within their department, or if publishing in the journal said, we want some type of letter from your institution saying that this was indeed not human subjects research. So the investigator goes, submits their project to the IRB for this determination, and they get a letter back saying, wait a second, this actually does meet the definition of either an exempt submission or an expedited research submission that requires prospective review and prospective approval prior to beginning the research. So at that point, the research has been done, you've submitted a manuscript, you've presented at a conference, and now you hear that this is indeed research. So what happens then? So this brings up regulatory compliance issues. Those have to be reported to the local IRB, and depending on the infrastructure of the IRB, there may be a compliance committee that looks at what happened and decides either that there is a corrective action plan that the PI has to follow, and or that the compliance issue was severe enough that it should be reported by the institution to OHRP or FDA, depending on which research regulations are hit. So it's very important to be able to differentiate research from other types of projects prior to beginning the project. And again, this can either be done at the department level, or it can be done at the institution level by contacting the IRB and asking specific questions about your project. There are criteria that IRBs and other institutional approval committees use to make that determination of whether the human subjects regulations are indeed part of the project, and those criteria are intent, design, mandate or endorsement, effect on program or practice evaluated, the population of interest, what the benefits are, if any, and plans for dissemination of results. So thinking about the criteria intent, anytime a clinician or an investigator starts a project, they have to ask themselves, what's my plan? What will I do? What is my plan for the project? And how do I plan on disseminating the information after the project is complete? If your intent is to develop or contribute to generalizable knowledge, then obviously the project should be submitted as research. With quality improvement, the intent is to improve a practice or a process within a particular institution or ensure it conforms with expected norms. And then finally, with program evaluation, the intent is to improve a specific program. So you could have a quality improvement project. Your entire intent is to improve your clinic, improve the outcomes of the patients that you see in your clinic. And then after the project is complete, you look at the data and you say, hey, this could really answer a cool research question. I really want to contribute to generalizable knowledge and answer this research question. That's okay, because the original intent of the project was for quality improvement. So in a case like this, what you would do is submit to your IRB and say, this was originally designed as a quality improvement project. We saw some really interesting data. We would now like to ask a separate question, a separate research question that was not asked for the quality improvement project, and contribute to generalizable knowledge. They will review and approve that. However, if you go into a project thinking, hey, this is quality improvement, but also I think I could answer a really cool generalizable question with the information, then obviously your intent up front is to do research. So prospectively submit that as research to the IRB. So there are some slight nuances. These questions come up a lot with investigators on campus as to whether they can, after they've conducted quality improvement, they can ask a generalizable research question. So the answer is yes, but let's talk some more about it and figure out the best way to submit this up front to avoid any type of compliance issue down the road. The second criteria that we look at is the design of the project. So with research, you may have randomization to different treatments, regimens, or processes. With quality improvement, you generally don't have randomization. For example, you know that hand washing is going to improve infection rates, so you're not going to randomize a patient to a provider that either washes or doesn't wash their hands. You're going to wash your hands for every encounter with patients. And then with program evaluation, the same is true. There's no randomization, but it may include comparison of variations in the program itself. Is the project a mandate or endorsement? With research, no, it's not mandated. But with quality improvement, it's either going to be mandated by the institution or the clinic as part of its general operations. And the same with program evaluation. It's going to be endorsed or mandated by the program. Usually that's a funder, again, as part of its operations. What is the effect on program or practice evaluated? With research, the findings are not expected to directly affect institutional or programmatic practice. The opposite is true with quality improvement. The findings are expected to directly affect institutional practice and identify corrective actions. As well as with program evaluation, the findings are expected to directly affect the conduct of the program and identify any improvements that are needed in the program. So who is the population for the project? So in research, it's a subset of individuals. And this subset is determined by statistical justification for sample size to ensure that your endpoints can be met. Whereas quality improvement and program evaluation include all the patients that are either in your practice, so in your clinic, or all the participants that are in a specific program. And the differences here, outside of including all or a subset, is that when you do have research, that subset of individuals must have an informed consent process, whereas with quality improvement and program evaluation, that necessarily isn't true in all cases. What are the benefits of the project? In research, participants may or may not benefit directly. In quality improvement, you expect that patients will benefit directly, but in program evaluation, you don't expect benefits to participants, but since you're concentrating on program improvements and whether the program should continue, you will see potentially a benefit to the program itself. Another important criteria is dissemination of results. So back to intent, contributing to generalizable knowledge. With research, your intent is to publish or present in scientific or research publication, as well as disseminate information at conferences through lectures. In quality improvement, you can disseminate by submitting to a quality improvement publication or, journal. The intent is to suggest potentially effective models, strategies, assessment tools, or provide benchmarks. So, as I mentioned previously, with quality improvement, if you're going to publish, you cannot use the term research, nor can you claim generalizability, but you can say, this is how we designed our program, this is what worked for us, and this is what didn't work for us. And then other institutions or clinicians who are reading or listening to the results of this project can extrapolate based on their particular institution. With program evaluation, the intent is to publish or present. The plan is to disseminate to program stakeholders and participants and suggest potential model strategies, assessment tools, or provide benchmarks. Again, very similar to quality improvement, and you can't use the term research nor claim generalizability. So this question comes up a lot where faculty want to publish and they say, I have to submit as research because I want to publish. No, you don't. You can publish QI and program evaluation, but you will typically, in anything you get from the IRB or from a department, it will say you cannot claim generalizability or use the term research. So I just wanted to go through a couple of scenarios. So the first is a program evaluation scenario. In 2012, University of Colorado Health launched a large program aimed at inpatient smoking cessation. The CDPHE grant covered 3 years of funding for the program. As such, UCH put together a team of independent investigators who collected data on approximately 3,500 UCH inpatients throughout the 3-year program. The team measured smoking habits throughout participation, cost effectiveness, and patient satisfaction. At 6 months post-intervention, 38.5% of those that participated in the full program were tobacco-free for the previous 7 days, compared to 21% of those who did not participate. Over 50% of patients receiving nicotine replacement therapy during their hospitalizations reported greater levels of comfort. Data also showed potential for both patient and hospital cost savings, particularly for those with CU Anthem insurance. Given the findings, UCH chose to invest in program continuation and expansion after CDPHE funding expired. So this is an obvious example of program evaluation, and one that was quite successful, and the program was continued at UCH. The next scenario is a quality improvement scenario. One U.S. hospital hoped to improve inpatient fall and injury rates using patient education videos and fall prevention visual signaling icons in conjunction with bed exit alarms. Trained volunteers in 4 medical surgical units in the hospital were asked to play a 4-minute video to patients. Icons of individual patient risk factors and interventions were placed on patients' bedsides. Exit alarms on patient beds were activated when fall risk was elevated. The main outcomes measured were the incident rate per 1,000 patient days for patient falls, falls with any injury, and falls with serious injury. So again, they noticed there was a problem with falls, and they instituted a project to improve fall rates within the hospital. So this is an example of quality improvement. So again, this will be posted on the PM&R Research Administration webpage. The plan down the road is for the department to develop a committee to review all QI program evaluation and not human subjects research being done within our department, provided it's not at Children's or the VA. The advantages of department review are hopefully a quicker turnaround with projects. Typically when you submit a QI program evaluation project to the IRB, it could take up to 3 weeks to get a letter back saying that it does not meet the definition of human subjects research. This committee will review projects from clinicians within the department or investigators within the department and provide a letter concurring that it does not meet the definition of human subjects research, which can be used when you submit to a journal for publication, or if you're asked for a letter by a conference that you plan on disseminating results at. The process and the forms that we'll use in this committee are currently under development, and we're hoping they will be up on the website soon. Here is the web address for the Research Administration webpage, and hopefully this helped provide a better understanding of research, QI, and program evaluation. Thank you.